Hello and welcome to another episode of the Steel Bones Amputee podcast. We are absolutely thrilled today to be joined by Dr Vijay Kolli from the Cleveland Clinic, and he is going to be giving us his thoughts on rehabilitation for amputees, obviously following amputation. So we're really thrilled to have you here, Dr Vijay. Thank you so much for taking the time out of your very busy schedule to join us.
Yeah, thanks for the introduction. So thank you for inviting me for this podcast. I don't usually do a lot of these, but I'm really pleased that I can be of some help for this group of patients. Thank you for that. So I am part of the rehab consultant group at Cleveland Clinic Hospital, which started about 3 years ago. It's a world-renowned organization, as we all know, and I'm lucky to be part of that organization within the rehab field. I come from an orthopedic background, hence my liking for amputee rehab. So I like orthopedics, musculoskeletal problems, and so on. So after my training in London, I chose to go into amputee rehabilitation and was lucky enough to get into the Douglas Barrow Rehab Centre at Roehampton within the NHS, which is my normal day job. And I look after a few thousand patients there. And the journey to Cleveland was more like 2 years ago, where there were plans to create a specialist amputee rehab pathway, just like any other specialty like brain and spine, etc., which they have amazing facilities and pathways. And therefore, we came together and we created a pathway, a group of clinicians, and I look after the amputee rehab side of things over there, working with my colleagues. So that's where I come from in terms of my background. I work with surgical colleagues. They may be vascular surgeons or plastic orthopedic surgeons and so on within the Cleveland and NHS as well. And obviously I'm part of the wider MDT. And we also collaborate with Dorset Orthopedics, which is probably the biggest prosthetic orthotic service provider in the country, trying to do the best for the amputees in the private sector. And Cleveland's got a lot of charitable events and reaching out and collaborating with other services as well.
Thank you, Vijay. I mean, we're really grateful for Cleveland Clinic's support of us and their proactiveness in helping us to raise awareness of the work that Steel Bones does and provide that for their patients as well. So we love working with Cleveland Clinic. Can I just ask, was there anything in particular that led you to the amputee? Well, were you particularly fascinated by it? Any personal experience in the family, or just ended up there?
It's more personal preference, I think, especially in UK. Slightly unlikely the rest of the world, where rehab clinicians sort of do a more general job looking after all sorts of patients. In UK, we have the, let's say, luxury choice of choosing whatever we like to do. Some people may do brain injury rehabilitation, some may do spinal injury rehabilitation, spinal cord, and some may do amputee, and others may be interested in more orthopedic trauma side of things, and some may do bits and pieces of each across the country. Obviously, my liking is amputee rehabilitation, just because of my background, where I come from. So I connect quite well with these kind of patients, and I like lifelong treatment, the holistic care, working with MDT and looking after patients for decades, which is quite rewarding because you form a relationship, you're there for them, and you see them develop and grow. Sometimes we have children aged 2 and they grow up in front of us, and that's quite rewarding to see what amazing things they achieve when they grow up. So yeah, that's why I like this.
Brilliant.
You're absolutely right, Emma. So yeah, spot on. Obviously the brain spine rehab, they may not achieve their full potential, which we all know. Some do well and some may be profoundly disabled. However, amputee rehab, if you do the right things at the right time in a, MDT way, then the outcomes are mostly amazing because people get on with life and do most of the things they like to. Of course, different people have different outcomes, but a majority of them really do well.
Yeah. Lovely, thank you. For you, what are the key stages of rehabilitation after an amputation?
Yeah, so I mean, obviously, there are 3, 4 stages in rehabilitation. If we say the first day after surgery, but I'd like to also add something before the amputation, especially for people, let's say, who had chronic injuries and they may have been living with disability, pain, loss of function, mobility, crutches, wheelchair, that sort of thing, sometimes for even decades before someone decides to do an amputation, and sometimes it's patient-led, sometimes clinician-led, sometimes it may be a random friend who suggested it to them. And therefore, what happens before the amputation sometimes is also important, because a lot of them are deconditioned massively. So just to have access to rehabilitation before the amputation, I think is also important. Having covered that, we'll go through the stages of rehab post surgery. So obviously, immediately after the surgery, you can call it, let's say, post-surgical rehabilitation, where the focus is on wound care, healing, getting the swelling down, making sure they don't have falls, trips, etc., keeping them safe, as well as working with therapists, safe transfers, wheelchair skills, and so on. Obviously, everybody's slightly different, and things can happen in the early days where people sometimes may forget that they just had an amputation, trying to get out of bed in the nighttime, that sort of things. And obviously, it's really important to look at it on an individual basis, because sometimes, people may be confused, or you may have an elderly patient who may have a fall, which can be quite detrimental. So that's the post-surgical, that is first few days to keep them safe. And then we can move on to pre-prosthetic stage, which is, let's say, about a couple of weeks, 2 to 3 weeks later. Following surgery, all being well, you'd want to get them up and start doing PAM aiding with the inflatable early walking aid, just to get them up, work their muscles, balance, good for bone health, blood pressure, etc. And most people would have stood up the first time after many months, depending on what the problem is. Feels amazing, sometimes they just get up in a PAM aid, stand in the parallel bars and think, wow, I feel good. And that's quite important for patients in their journey as well. And then you start to get them a bit stronger with strength, and continue the transverse wheelchair, practice in the parallel bars, get the wound healed fully, get the swelling down, and so on. At the same time, you'll be working with prosthetics to see, what's the right time to take a cast, manufacture the prosthesis, which people are very keen about, because they want to move on to the right step, understandably. And then we move on to the third stage, which is the prosthetics. Yeah, so they take a cast, and a limb gets manufactured in a week or 2. They get fitted, and they work with the physios and the prosthetists together to make sure the socket fits well, because that is the most important thing. Let's say, in principle, a prosthesis, if it's comfortable, people feel that sort of it works well for them, it's part of their body, and they get on with it. And it does take several days, if not weeks or months, to get used to having a hard plastic socket on the residuum. And different people do differently. So then, they practice with physiotherapists to get used to this. They build up the tolerance. They work more and more, depending on whether they're coming outpatient or inpatient. We can offer inpatient rehabilitation, luckily, but most of the services across the NHS certainly are outpatient based, where people may be traveling an hour and a half each way to get an hour of rehab, which can be tiring. So, and if you have an elderly patient, for example, they'll be knackered by the time they get there. So you really got to work with the patient to see what works for each patient. But then the principles of, how the rehab are quite clear. And it's not just about walking. We make sure that they get the whole body workout, really, because although we consider walking is just another thing, then it is a complex task in itself, and pretty much every part of your body should be working together to achieve a good gait. And then so they increase their balance, their strength, their stamina, tolerance with prosthetics, etc. And then once they achieve a safe level of ability, whatever it may be, depending on individual persons, they go home, and then it's a complete different ball game altogether. You know, get out into the real world, because up until then you're surrounded by a group of professionals. You feel safe and you can talk to anyone anytime, and then suddenly you're out. One patient I remember saying it's quite scary out there when you sort of say, okay, well, you're ready to move on now into the real world, and different people cope with it differently. And then it's really about integrating social life, family life, exploring, going back to job, your hobbies. Some people take up new things that they haven't done before, or some people may have to change their lifestyle according to what's possible and not. So there's a lot going on actually, and it's really quite a lot of cognitive burden for patients, really, because they've never been there, they've never done it, and suddenly they have to learn so much. And sometimes it takes months. I say I learn something every day, and I think every patient learns something every day new. Might not just be professionals, could be a friend or someone on the internet or someone like yourself, and that's all really important. Yeah,
I think that inpatient residential rehab is key. When my husband lost his leg in 2007, it was very different times then. He was able to stay. He was very young as well, so he stayed in. This is at St Tommy's, right. I think for 6 weeks, and he was working, walking. Within 6 weeks, the physio team there were amazing. However, now I very, very rarely hear amputees are sent home. As soon as they're safe, safe, wound clean and whatever else. I know that there's 4 NHS rehab, I think residential, there's Douglas Park, St Mary's, also Norfolk, Norwich, Cottage.
Coleman Central,
Yeah, exactly. Yeah. But I'd love to see more of them, but I realise we're in a world of NHS extranet.
Certainly some centres have explored it, but obviously it's down to finances and how the trust supports and all that. And there's no doubt that a small group of patients would really need that intensity under one roof where people work together. It's not for everyone. Some people say, I've had enough hospitals, thank you very much. Sleep in my bed. Whereas other people, it would be really nice to have the option of residential rehabilitation, and that's what we can offer at Cleveland, all under one roof. There's literally nothing that cannot be done at Cleveland Clinic.
It's incredible. The difference I see in people is phenomenal when they stay residentially. So brilliant. What are the most common challenges that people come across in their rehabilitation? If you were to name the top 3, for example, what are the ones that you're always trying to help people overcome?
Yeah, I mean, it really depends on what stage. I think it could be anything from pre-amputation, really. Somebody's in hospital with, let's say, a badly injured leg or an infected leg, for example. I go to the respective surgical wards and talk to the patient. Sometimes that is what they need at that time, is to have the assurance that it's not the end of the road and things will get better. And obviously, it's quite difficult for anyone to just turn up and say, this is what I expect you to be in 6 months, 1 year, 2 years' time. And therefore, part of my role is to just look at the whole person as a whole, considering, this biopsychosocial holistic assessment, and then give them realistic expectation of what they'd be doing. But those sort of issues carry on through all stages of rehabilitation, and things start slightly changing. They have an amputation and they want to move on to the next stage, which is, when am I going to get my prosthetic? When am I going to be walking? And then after that, it's, when can I go back to work and play golf or whatever it may be. So initially there's that anxiety, uncertainty, frustration, anger, whatever you call it. Sometimes people cannot come to the sort of terms that somebody may have caused that accident and led to this injury. It's really difficult to get to terms with it, and other times it is what it is. They may unfortunately get some nasty infection and so on. And to adjust to that is quite a difficult task in itself. Some people can do it themselves, let's say. I see people who say, well, it's done, I'll get on with life. There's no point, worrying about it. It doesn't mean that they will never have any issues with it. but at least they sort of tried to move on. They've dealt with that problem and they try to move on. Whereas other people, they find it really difficult. I see patients 10 years down the line, they've really not come to terms with the fact that they've lost a leg and everything that comes with it. So it's all those mixed emotional patterns, let's say. Body image, some people clearly are far more affected than others, especially, let's say, females, but I'm not sort of generalizing it. I know people who work in the police who lost a fingertip and they just can't get out, that sort of thing. So we can't really generalize anything, and it's a personal thing. And of course, there's the problem with adjustment and low mood, depression, anxiety. Sometimes it could just be being in hospital itself. The thought of being in hospital itself is traumatic because they've been through so much. Those people say, thank you very much, I'll go home and have my rehab, doesn't matter. And then you got nightmares and flashbacks, especially if they're involved in accidents and so on, PTSD. And importantly, I think, some people, more and more I speak to patients and relatives especially, say, how are you feeling? And they just sort of look at their partners and say, maybe he or she can answer the question. And it's surprising how many times people's personalities change, especially if they've been through a really long journey. They're just not themselves, unfortunately, because of the amputation itself. They get snappy, angry, they lose patience, and they shout at family members who they really care for. And those things start to affect relationships, make things difficult for everyone, really. Not intentionally, but you really got to think, of the patient, see where they're coming from, and sort of walk with them, support them. And it's not one person's job, really. It's everyone's job. Family, friends, psychologists, MDT, the whole team. So that's one thing. And then the physical aspects of it, after amputation, the challenges sometimes are, phantom pain management can be an issue, as we all know, at least in the first few months. For people, in our experience, if they have really complex psychosocial backgrounds, they tend to unfortunately have more phantom pain. There are dozens of treatments for it, including some recent surgeries and so on. But nothing offers a 100% guarantee for phantom pain treatment. And we know that a lot of triggering factors can make it worse. So it's really a package of different things that can be used to manage these problems. People get deconditioned, they're weak, especially if they're bedbound. And just trying to wake up their muscles and get them to do a bit of exercise is challenging, because a lot of people generally in the community don't normally exercise for the sake of it, and suddenly they are expected to do several hours of working their muscles, and that's not easy for everyone. Some people love it, some people absolutely hate doing exercise, but then unless they put in the work, they can't really get through the rehab or achieve their outcomes. So there are different kinds of challenges. And then, as you move on, 15, 20 years down the line, people may get back pain or arthritis because of walking with prosthetics and so on. And, it just goes on. It's obviously quite impossible to list out all the complications, but generally speaking, these are the things that come across, physical and psychological.
Yeah. And I know if you've lost one leg, so important to look after the full remaining limb, isn't it? Absolutely. I think that can so often be forgotten because the focus is on to ensure the little leg is all right, but actually almost preserving that full leg is so important.
So especially for people who have diabetes and, let's say, lost their leg from smoking, it's really important to try and educate people about the impact of that on the other limb, and having access to diabetic podiatry or orthotic services. So I make sure I refer every single patient, I ask them to get their shoe off.
Yeah, I love that.
I sometimes say, listen, I'm not worried about your stump, it's healing well. Let's look at your other foot.
Yeah.
The number of times I see a sore or something not right with the other foot is surprising. So it's really important to educate patients. We have leaflets as well to say how to look after your other foot. And
amazing.
Unless you make it important, I think a lot of people really don't appreciate. And if they lose the other leg, it becomes not just doubly difficult, but far more difficult to walk with two prosthetics.
Completely.
even if they're below knee. And unfortunately, it's too late for some people. So yeah, education is the key. Ongoing education from, everyone, not just health professionals, people like yourself,
Yeah,
and other patients.
educate ourselves, because things
Absolutely.
have changed so much from Douglas Bader's day
Yeah.
to now. We have to constantly be our best research, don't we?
Yeah.
Our best research assistant. And with the mental health, do all of your patients at Cleveland Clinic automatically access a psychologist? Or I realise it must be different for everyone, but would you recommend that even if you feel you don't, you should? What's your stance on that?
Yeah, I mean, generally I say that for most, but not all, psychology is half the game, I say.
Yeah.
Yes, some people are far better prepared for the journey, but it doesn't mean that it doesn't affect anyone down the line. Some people may just shut themselves, get the job done, and then and down the line they have problems, and other people have a problem starting, and so on. There's no right or wrong, really. Some people adjust quite well. But what I'd say is definitely offer. Yeah, it doesn't have to generally come from a psychologist per se. It'll be ideal because they are far more better trained to deal with these things, whereas a family member or a friend may not be that prepared. But sometimes you'll be surprised that the patient may not like to talk to a psychologist, even if we offer and we know that they need them, but a good friend may do a much better job.
Yeah.
Even if they don't know anything about psychology, they may actually be far more helpful for that particular patient to come to terms and move on. For example, let's say someone in your charity, a good friend, they really trust and connect, may be far more useful than a qualified psychologist sometimes. And it just really depends on the patient. But I think it's really important we offer it, talk to them, and let them talk, because shutting the doors and trying to not deal with it is not the right thing to do, because it will come back at some point. You can't just shut it and lock it up somewhere. It's going to come back every day. Well,
what advice would you give to a family member whose amputee has shut off? And is it just asking questions, just keeping talking as best possible? What could they do?
You mean the family members?
Yeah, the
What
family
should
members.
they do?
Because
Okay, for the family member.
we speak a lot to different family members, and they say she doesn't want to talk or do anything about it. And we always say, just keep talking. When it's ready, let us talk. But I feel like I want to say something more to them, and perhaps you've got some other advice.
I think a clever way of dealing with it is, there's all sorts of, let's say, thinking processes with amputees. And obviously, it's really difficult to find a pattern. But some people just say, well, I don't want to talk about it. It's too traumatic. Some people say, I don't want to because I don't want to be perceived as a weak person or a disabled person. I want you to treat me just the same as yesterday. And they're all absolutely right. And the problem is we can't really get into the mindset of the person, how they feel and how they want to deal with it. What may be useful is maybe just politely asking them, listen, whatever's going on in your head, just put it on a piece of paper. People are good at writing. Some people may do it. I don't think everybody will do it, but some people may find sitting in a corner and just writing their feelings, putting it. But then you really understand where they're coming from. It's always good to see what they want rather than what we're trying to offer, if you know what I mean. It's almost like raising kids, isn't it? Really?
Yeah.
Sometimes you got to do it both ways, because we think something may be better for them. Sometimes it isn't, and you just got to listen and see where they're coming from. So it's really leaving it open and say, listen, okay, fine. If you don't want to talk about it now, that's fine. But you're not yourself, and just not make those judgments, because the partner may think, I know you're not normal. I'm trying to help, and you're being not very helpful to me or yourself. And that can clearly be quite frustrating for them, and they can get a bit snappy, and then it all when you're actually genuinely trying to help the patient. So just give them space and see how they want to deal with it. and explore other ways. It may not be a psychologist, it could be anything. Sometimes just shutting everything off, going on a holiday somewhere. Sometimes, who knows, they may not want to go with the family, go with a mate or somewhere. It can be anything. Just say, what do you think will help you? And it's difficult, really, because sometimes it can be anything, right? They may say, I just want to go for a week's holiday. I don't want to talk to anyone. And if that's how they want to process it, so be it. Or sometimes you may need like couple counseling, sit down together with a psychologist, that sort of thing. Could be anything.
I think that advice is superb, and I think it's actually going to save a few marriages. I think it's really, really important.
Yeah, it is quite important because genuinely some people are trying to help and they feel helpless, and it all goes this way or that way.
I think that's superb. Thank you for that. And one last question, Vijay, if you don't mind. What advice would you give to someone struggling with motivation or confidence during rehabilitation?
Yeah. So again, it's a pretty individual thing, and we come across this pretty much every day within the NHS, sometimes in the private sector as well. It comes down to what motivates you. And it's absolutely different for all of us. Yeah. The way I look at it, if you ask me saying, Vijay, what would you do if I had forbid something? I would look at it like, okay, what would I do? What would really, really motivate me? There'll be one or two things, yeah. A fear of something happening, or the love for something else, or whatever. It could be looking after your family, or I don't know, could be anything. Right? You find that one thing that really, really motivates you, really gets you out of bed. Yeah, that you won't stop at, saying, no matter what, I will get out of bed and do this. And interestingly, it may not be for you, as in the patient. Sometimes it's someone else who motivates them. It's not like, I want a better quality of life, I want to get back to my job, that sort of thing. It could be, let's say, I don't know, their 2-year daughter, and they're like, I'll do anything to provide for you, I'll do anything to walk in the park with you. Or whatever. You see what I mean? And so they have to find their one thing or two things or whatever that really motivates them. It's so personal, and then link up all their goals to that, if that makes sense.
I think that is going to help.
Find their motivation instead of us saying, you can do this, let's get on it. So we can push them as hard as we can. It has to come from within, isn't it? If they say, okay, if I got to play with my 2-year daughter in 4 months, or standing on my feet for her birthday, could be anything, Well, I really got to put in the work.
Yeah, absolutely. And I'm sure I did a podcast with Lord Craig McKinley, who I think was at Roehampton as well for a little while. And he said, we are our own best, amputees are their own best health professional, their own best. Obviously, it's a whole team as well, but they are so important in driving what they need, what doesn't work, and it really
what works for them. You're in charge. Absolutely. That's the thing with rehab, is it's not like go and have a tablet for diabetes or have your appendix out. It's not that. Rehab is, all personalized, and we just, we have a few tools which work for most people, and other times we really got to go outside the box. And, and sometimes it's the patient who actually tells us, listen, I want to do it this way. And the health professionals may be trying to do it in another way, which may not be working. You see what I mean? So sometimes you really got to listen to the client and see how they want to do it. And ultimately, you want them to achieve their goals and, be successful in what they want. And the other thing about, we just want to talk about, technology and all that stuff,
please.
Going on in the world, the prosthetics world has moved on quite a bit. Last 20 years, we got microprocessor, feet, ankles, and lots of things going on research-wise. And every day or week, there's a new thing coming up in the market by, different parts of the world. So some of the things we are now aware of, which is artificial intelligence, and, technology is moving on so quickly. And there have been some cutting edge, let's say, surgeries. Osseointegration is one of those things. It's not too recent, but at least in the NHS, in our service at Roehampton, we've been dealing with osseointegration for about 26 years now. So that's our oldest patient. So it goes back many years ago. And then there's targeted muscle renovation and, all sort of nerve surgeries for problematic nerve pains and phantom pains and all that. The evidence is still sort of not concrete, and we're working with policies in the NHS and outside as well. It doesn't work for everyone, but for the right patient, these sort of surgeries work really well. The question is, how do you find the right patient? And most times it's about having the right people in the room, which could be, a surgeon, a rehab person, prosthetist, physiotherapist, etc., psychologist perhaps, all in the room. So we don't leave anything unexplored and do it for not so right reasons, because surgery has its own risks. And then, you got virtual reality. There's amazing stuff going on. If you've not done so, try and get a VR headset. Yeah. And buy some games or programs. Because the thing with rehab and exercise is that not many people see it as a fun thing, if you know what I mean.
Yeah.
Because they think, okay, you want me to be this motormed or go on the treadmill. It's so boring. Functional rehab, as in you get them to, let's say, you put a headset on and suddenly they're in a Miami beach and there's an apple tree and you're picking up apples from the tree. Yeah. If you're picking up apples from a tree and putting them in a basket, so you actually have to move 4 steps, bend down, pick an apple, put it in the box, put it in a basket, that sort of thing. That's real fun, right? And they really love it. Or they may use I don't know, tennis bat or go canoeing, that sort of thing. Yeah. And they're really immersed in it. So you get a good workout for 20 minutes without feeling like an exercise. So that's a really good way of getting people to do stuff, that they enjoy. Yeah. Unless we enjoy it, we're not going to invest anything,
Never heard
right?
of that before at all. So I think that's wonderful.
That's something, I know they're relatively expensive, but a really good piece of kit. You can get it, then somebody would love it. I think everybody would love it. If you have something that they really like. And sort of more advanced technologies like brain computer interfaces where, just like now we want to move our hand and we're doing it, but the prosthetics are not catching up. Technology still not there, but there's lots of research going on in different parts of the world, in the US and maybe to some extent in Europe, where you just think of something and your prosthetic hand works with you intuitively without having that clumsiness of having to train for hundreds of hours to master it, which is quite difficult for people to invest and train. So, in 15, 20 years time, we wouldn't be using these sort of prosthetics anymore. It'd be far more advanced, and you can get sensory feedback and far more intuitive way of using prosthetics and all that. So we're moving on to something really exciting. All these young people want to see something far more interesting.
Fantastic. Thank you so much for sharing that. I think it's really positive and encouraging for patients to know that there is more. It's consistently developing each day, each week. So, thank you so much for that. Was there anything else that you wanted to, I realise we've dotted around the questions a little bit, but is there anything else that you really wanted to share?
Yeah. So there's 2 things. I think the way I see rehab and health, let's say one should take own responsibility, not just for amputees, clearly. We all should take responsibility for our own well-being and health. I see regular form of exercise, physical exercise, but also, being mindful and looking after mental health is equally important. And just investing a little bit of time. And I, deliberately use that word, investing. Yeah. You save up a few pounds so that you contribute to your pension. It's literally the same. Whether you're an amputee or not, is to invest a little bit of time every day to look after yourself, keep yourself happy, and do what you really enjoy doing. Also exercise. The simplest form of exercise is just get up and go for a walk. It may be 50 meters with a Zimmer frame in the garden, doesn't matter, or you're going up mountains, doesn't really matter. Whatever you can do, one should consider doing it little and often, because sometimes doing something too much, you're in bed for the next 2 days, no point really. But sort of trying to maintain that good lifestyle is really important. It's a good investment for future. If you put in a little bit every day now, you will see the benefits 20 years down the line. As in, yes, you may slow down a little bit, but you're still walking and you're still independent. You can go to the shops and travel in 20 years' time. Whereas if you don't put in the work now, there is only one thing that happens to human body. And we all know, scientifically proven, that you lose about 10% muscle every 10 years, after 30 or 40 years. So as people get to 60, 70, they've lost a significant amount of muscle just through aging, nothing else, really. And that's regardless of an amputation, by the way. Okay. Obviously, if you have an amputation, that side of that limb is going to be a little bit weaker relatively. The important thing is to maintain the strength with whatever is left. And the only way one can do that is to exercise whatever they can do. You don't have to get out of bed to exercise. So that's one of the myths that I speak to is people, amputees sometimes say, my leg's not fitting me properly. I'll put on 2 stone. Yes, there is truth in that. I'm absolutely not denying that because, walking is limited and therefore you're not burning calories, etc. But there are literally hundreds of things you can do to exercise without getting out of bed, or sitting in a chair. And that's something they need to explore. Sometimes, people don't see it. I don't necessarily blame anyone, but it's our job as professionals to identify and say, okay, well, you can't wear your leg, you can't walk maybe for a week, 10 days, or you're limited how many hours you can use your prosthesis. However, when you're watching TV or you've got a bit of spare time, or even before you get out of bed, you can do X, Y, and Z exercises to maintain your core or, your muscle strength, etc. And people can do stationary stuff, burning calories as well. But having the knowledge and the resources to do it is not easy because patients don't know. A lot of people don't actually know. Others know but don't want to do it. So it's different things, For people who want to do it but they're not motivated, you need to find the right place.
Motivation.
Create the right environment. Sometimes they may be not willing to do it in their house, just organizing a little community thing. I think we last year somewhere there's a lovely initiative in Leeds where they created a communal service post rehab ongoing exercise therapy group sort of thing. And people just go there, love it, they work out with 20 other people in a normal gym, whatever they can do. That sort of thing where people just love, have fun, gain from peers and so on, rather than sitting at home and asking them to work out, which is not really appealing for some. For some, that's what they want to do. So it's really looking at what works for what. And of course, we can't fix everything, but it's just raising the awareness. And the other thing is, people sometimes feel that only if I had the best prosthetic in the world, then, I could walk a lot further. The reality is, the way I look at it is your body is one thing and the prosthesis is another thing. You can have the most expensive tire on your car, but if the rest is not working properly, your engine, the whole thing, you are not going to race. You're not going to race. That's absolutely that. If your engine's good, your body's good, everything's working well, yes, you have the best tires in the world. Of course, you're going to do well. But then ultimately, it depends whether you're Michael Schumacher or someone who drives for a living. So there's so many things that really come into that. So what I'm trying to say is, yes, a good fitting prosthetic is, pain-free, fits well, and suits your, mobility level is absolutely crucial. Fully agree with that.
Completely.
But what you can and can't do is up to the patient, really. If you got a good prosthetic, someone who's able to can walk 4 miles. If you have a slightly more advanced prosthetic, yes, you may be able to walk another 1 mile. There's no doubt about that. But it doesn't stop you from doing things. So if you have a prosthesis, very wise advice. So invest in your body, keep healthy and lifestyle. And if the prosthesis doesn't fit you well, of course, go back and say, listen, doesn't fit me well. Can I have something better or adjust the socket? It's not the components, but usually the socket's the problem. Yeah,
I think that is superb advice. No, that will really, I think that's so important for everyone to remember. Really grateful for you saying that, Vijay. And that goes not even just for amputees, does it? It's all of us. You know, if we don't look after ourselves, mind, body, we're not going to get very far.
Yeah, ultimately it's our job, isn't it? Because, you know, nobody is going to look after your body. You know, I am in charge of my body. That's it. Literally, no one else will look after it. They can tell you whatever they want to, and it's up to us to, you know, keep ourselves healthy and happy. So invest in yourself. Last word.
Well, we are Still Bones, a charity serving the limb difference community in the UK. Our mission is to empower amputees and their families to live life to the fullest. It is completely free to join us, and you can register at stillbone.co.uk at the big blue button, register at the bottom, and you can also ring us on 0333 606 930. We hope you enjoy listening to the podcast today, and we look forward to speaking to you soon.